Hi friends. Okay, we are going to do a Facebook Live today, and we're going to hold space and check in with all of the midwives around the globe who are tuning in, and everyone is feeling really anxious and really overwhelmed. I've heard some midwives talk about feeling lied to by the government. I've heard midwives posting about Facebook's algorithm taking down their posts. Obviously, we've heard a lot about missing toilet paper and low supplies of groceries, and it's a really crazy time. So making space to come together and just breathe together is one of the most important things that we can do together. So I'm really honored to hold space digitally for everyone to come together. I am in Perth, Australia, randomly. I did not intend to be here just even a few days ago, and it has become a nice, safe refuge for me to land as borders close. And it felt important for me to have this extended time in an English-speaking country. My Bahasa Indonesian is not up to par yet. So I did come to Australia, and it's beautiful and it's temperate weather. It's so incredible to be out of the tropics because your skin is just always wet. You're just always sweating. So it's quite a treat to be here. I think it's like 65 today. I wore a sweater yesterday. It's amazing. They're actually heading into winter here because I'm in the southern hemisphere. So that's really crazy. Anyway, I just wanted to invite folks to say hi, comment where you are in the world, connect with each other, send love and attention, and also connect with our guest tonight, who is Lisa Varnes-Epstein, who is a midwife and a physician's assistant with a bunch of other titles that we'll ask her to tell us about, and a lot of experience working in the low resource environments, and even environments where there is an actual outbreak. So she has some tricks and techniques and just some lovely energy to share with us. Let's see if we can get her online now. Okay. See if she can come on. There she is. Well, there's her show. There we go. Hi, friend. How are you?
Hello. Can you see me okay?
Yeah, we can see you perfect.
You have to be able to see my hat.
Oh, I love your hat. That's fantastic. Oh my gosh. Tilt down one more time so we can see it again.
This is my meconium hat. This is when I talk about meconium. I put on my hat so I can feel, the poop.
Love it. Shit happens, and you are right there in it. I love it. Love it. Well, we have some folks joining us from all over. Yeah, we can see pretty well. You've got a good distance from the camera, but because you're such a distance, you'll have to talk up a bit.
Okay, but you can see, do I need to tilt up here at all like that?
No, I think it's good. If you lean back, then we see all of you. Yeah, perfect.
All right.
So tell us who you are and where you are in the world.
Well, so my name is Lisa Varnes-Epstein. I'm going to take this off. This was just my, hi everybody. I'm wearing my poop hat. And
I really love it.
Try to get used to making sure I know how to wear one of these again.
Yep.
I'm in the mood. So this is my service baby. So some people have service dogs, and some people have service parrots, and some people have service cats, but tonight I have a service baby.
Awesome.
There we go. So my name's Lisa Varnes-Epstein.
Hoping to keep you calm.
Yes, exactly. So many of you know you probably haven't seen me do anything quite like this before. So I'm just hoping that I have a lot of friends out there and you're going to walk me through it, and maybe I'll have a few things you want to hear about tonight.
Thank you.
Okay. Okay, so I will just let you know who I am. So again, I'm Lisa Varnes-Epstein. Just a little bit about me for folks who are not from the Midwest and haven't seen me in action doing some of the midwifery classes. I was trained as a physician assistant in the early 1990s and did family medicine. I still do family medicine, but I got very turned on to home birth because I had my first baby at home. So this was at a time when I was living in West Texas, and I was doing, if you ever watched Northern Exposure, where Joel had his 4 years that he had to be up in Alaska, I had 2 years that I had to be in Terra, Texas. And it was a very similar experience out in the middle of nowhere, 2,000 square miles served by this one little clinic. And we found ourselves with our first kid, and then ended up traveling to San Antonio ultimately to find a midwife who would catch a babe in an efficiency apartment. And it worked out great. So I got very, very interested in the home birth movement, and I wanted to become part of that. So when we moved to the Midwest, I brought that interest with me and had a few more babies at home and ended up apprenticing with some of the midwives in the greater Madison area, and particularly did a lot of work with the Amish and the Plain communities in this region. And then something really fascinating happened. I had the opportunity to work with a physician some of you may know about, but he's a family practice physician who had his own clinic in a rural area in a town of 500, about 30 miles north of here. And he opened up a birthing room in his family practice clinic. So he was not regulated in any way, shape, or form as a birth center per se, but what he was trying to do was offer the Plain community an opportunity to come birth in the clinic because they didn't seem to have enough Amish midwives to kind of go around and take care of some of the women. And they also ran into a few complications with the high parity. So, women who were having pretty normal births in the beginning maybe were running into some troubles further on down the line. So he was able to serve that community, and through my work with him, I got to work there for about 15 years and apprenticed and mentored many midwives that were coming through a newer program, Southwest Tech, through Sherry DeVries. And it was a really special experience. So that was pretty cool. I mean, being able to be in a family practice clinic, we saw anybody who we thought we could manage reasonably in an out of hospital birth setting. And we had a few more tools at our ready, but the very fascinating thing was watching this family practice physician sort of shift and turn his idea.
Well,
and so he really became a very hands-off physician.
Awesome.
Okay, are we there?
Yeah, I think you're just having a little lag in your delay, but it's okay. Go ahead.
Yeah, we're on satellite here, so that might happen more than once for sure.
Yeah, we'll just stay with it.
Okay.
So then you got an opportunity to work overseas several times, right? Tell us about that.
Right, so I was in the Peace Corps in Sierra Leone in the 80s, and obviously Peace Corps experiences are very profound and life-changing, and I was able to live with a village on the Guinea-Sierra Leone border in the late 1980s, and this was before the Blood Diamond War and when things really kind of went to pot, and in Liberia, both Liberia and Sierra Leone. And so that country got shut down for probably about 14 years, and then finally went into restorative changes and opened up again in the mid-2000s. So Michael and I had made a commitment to each other that we would both go back to our Peace Corps countries and bring the kids with us. And so I was the first to do that, and in 2009, we took the kids, or actually I think it was 2011, we took our 3 kids, and I had made contact with a clinic in the district town of where my village was, and then we were there for about 2 months working with, they had a birth program, and they had outpatient clinic care, and it was a program that was run for Sierra Leoneans by Sierra Leoneans. So it was really one of these programs that you wish everybody could see how well this worked, because it was supported by a board that was partly Americans and partly Sierra Leoneans, but it was completely run by the Sierra Leoneans, and very informed, of course, by the culture, and very well received in that community. So I went back, awesome. And I got to start feeling like I could give back to the communities that had really been so formative in my early years, and basically raised me in a way that you can't get raised here in the States.
Wow.
So that felt pretty cool, but I was already an NRP instructor at that time, so I went back not so much, I wasn't there to save babies or even catch babies, but more to mentor midwives and also to learn from the midwives who knew exactly how to work in a lower resource setting for their own people. And so I learned a lot of tricks of the trade doing that. And then Ebola came along a couple of years later. I went back with the moms group, Midwives on Missions. I did do a with them. And then I went back with the opportunity came up to work with Partners in Health. And Partners in Health was the only Ebola response organization. There were only 3 of them, Doctors Without Borders in Gaul in Ireland, and then Partners in Health with Paul Farmer. And Paul was very, very committed, because that's sort of the philosophy of the Partners in Health organization, is that you work with the Ministry of Health. So the other 2 organizations, they just set things in the way that made sense to them. But Paul Farmer partnered with the Ministry of Health to work with the Sierra Leonean Medical Corps and partner us with them, and so that we could have a combined response, learn from each other, and then address the rather intense situation that was unfolding there. So I also then worked in the Ebola treatment unit at Princess Christian Maternity Hospital, because a case definition for an Ebola patient was basically you had to be bleeding, and there were many women who were having bleeding during their pregnancy, and it was very uncomfortable for all of us to take women who may not have had Ebola, but because they met case definition, we had to put them in this unit. And then we did the best we could to separate that they would not go into a unit without Ebola and come out of the unit with Ebola, if that makes sense.
Right. Yeah, really devastating requirements there. Wow. But of course, how do you separate it on a global way? Yeah. So fascinating.
Right. So not the easiest of jobs, admittedly, and certainly in general, nothing really good was happening there. But we did have many women who survived that experience and were able to be Ebola-free and come out of that and hopefully get the kind of care that they needed, even in a unit like that. But it certainly was challenging. So I did that. And so when I had downtime, which was really fun, I got to work with the midwives, because they were also in the unit. And we did all kinds of just review of, like, what do you know about this? What do I know about that? How do we put that all together? We do some case scenarios. I brought babies with me. I brought all my stuff, because I'm like, who knows when we're going to have, instead of playing cards, why don't we resuscitate babies and see what that looks like? And
oh, you're such a midwife. I love you. Yes, exactly. Let's practice NRP.
Like let's just what that looks like. Exactly. And also just what, I wouldn't say the myths, but really kind of reviewing why babies might not be breathing and what that might look like in Sierra Leone, and what other things besides a NRP protocol are going to address what's going on with this baby. It might have a spiritual anomaly. There may be a possession going on that needs to be addressed as well. So you have to really have those different, the spiritual algorithm and the emotional algorithm, and then this physical algorithm, how you're going to address a baby that's kind of
and there's so much overlap. Like, we can have both going on, and very fascinating. That's a topic for a whole nother day. We could get into that. Well, so Lisa, you were saying that you picked up some real tricks, at least on the physical plane. Maybe you want to share others as well, but some tricks for when you're practicing in a low resource environment, and that you may have only limited tools. Will you tell us more about what you've learned there?
Yeah, I'd like to, as I was thinking about this, Augustine, I struggle a little bit with this idea of a low resource setting, because we have in our mind's eye this idea that there are a group of people who are in a birthing story is unfolding, and certain things are not available to affect the best outcome. Okay, so that's sort of, I guess, the premise. But maybe if we reframe that just a little bit, and we think about, and we kind of turn it around a little and say, if we were to look specifically at and embrace the power of certain assets, I'm not sure that even Sierra Leone would be considered a low resource setting.
Love it.
So it's the idea that there are all different kinds of ways to be poor.
Mm-hmm.
All right, we can be poor in spirit, we can be poor emotionally, and we can be physically, bereft. So what I was thinking about was this idea that if you take if you look at the resources as very, very holistically, and in the holistic sense, if there's kind of the trinity of holistic care, and that's going to be the physical self, the emotional self, and the spiritual self. And if we look at each of those individually, even from a birthing perspective, I would be hard-pressed to say that folks in Sierra Leone are in a spiritually low resource setting. I would be very hard-pressed to say that the people that I know in Sierra Leone, like we're just using them as an example, would have a low emotional or community support resources. I would say no, that's not the case. And then even when you look at the physical resources that are required for most normal physiologic birth, when the complications don't come up, and we know that those are 9 to 9.5 out of every 10 births, then I would even say then the Sierra Leonean folks, or people that we might consider in low resource settings, actually have generally the tools that they need to attend a woman, and the woman has the tools that she needs to attend herself. So if you're kind of thinking of that as a dyad or triad. So I just wanted to challenge that idea that if we look at the physical resources, which are going to be environmental, so catching babies in a place that is not keeping a baby warm, or having potable water, or having a light source for, let's say there is a resuscitation and you need to be looking at skin color just because it might help you make some decisions. That's sort of the environmental side of things. And then when you look at your actual tools, it's what's in your bag. And one of the things I got to see Robin Lynn the other day on your feed, which was such a treat because I hadn't seen her for quite a while.
Isn't she a dream?
And I saw her pull out. She didn't spend much time on it, but she pulls out her birth bag, which is big, and I'm sure weighed less than 5 pounds, because Robin Lim knows that the things that we actually need in terms of tools, besides our hands, and certainly besides our heart, but besides our hands, are so few. There's just so few, and most of these settings that I've been, people seem to have, some of those things available.
Yeah.
And people certainly in their own birthing environments, culturally and geographically, know what those tools are.
Yeah.
So I thought about just the idea that sometimes we might be able to actually say that these are very, very resource-rich settings that have a couple of gaps that are sometimes make it so that there's not the best outcome, and then we just hone in on those and say, that's because of this poor outcome, then it's because it's a low resource setting.
I love
this
distinction that you're making. I really love it. It actually, pre-pandemic, that description could apply to the U.S. actually really well, is that we have this hyper focus on the few little gaps without an awareness of really how many riches we have, how much resources we do have. So I love that distinction. And certainly there are many community-based birthing families who are very much low emotional support, emotional resources, or very much low spiritual resources, because there is no real spiritual community in many parts of the US now. So we have lots of stuff, but we don't have the other things. So I love that distinction you're making. So now the world, or, you know, the US is panicking because we'll have less stuff, but really, yeah, not. So thank you for that. I love that distinction. Will you tell us? Go ahead.
I would say, oh no, I was just going to say that when I think of what is the emotional resource, or the imposition of the part of the emotional resources that are being impacted most by the C-19 pandemic is probably fear. And as we know, fear permeates all of your life structures. And if we were to say that that we were needing to make some sort of strides or attend to not only the fear that we have in ourselves and attending others, being close to them, but also, of course, the fears that the mothers have, or the birthing people have, who are afraid for themselves and perhaps for their baby. Fortunately, at least the very latest information that I got, in fact, today, was that they're finally pulling out a lot of the data that China has already demonstrated 80,000 plus whatever infections. Many of those were pregnant women, and they are not finding horrible outcomes at all. So we don't have it like in a paper, in a scientific paper, but the data is out there, and people are looking at it very carefully right now. So I think some of this fear around birthing I feel like it can dial back a little bit. I think it's been promoted too much without a lot of information to really warrant that kind of concern.
Yeah, absolutely. And then there was this big news splash about how the UK just found their first positive baby, and they're trying to figure out if it was a downline infection or if it was, exposed right after the birth. And now there's a big conversation going on in the MDG, I always forget the initials, but that lovely family practice discussion group led by Michael Klein. You know what I'm talking about? What's the name of the group? Do you know what I'm talking about?
I forget their name.
But you know what I'm talking about. Well, they're having this whole conversation about if you have how would you manage resuscitation? And now they're talking about using face masks for the resuscitation. And then there was some discussion around water birth, and it being a potential vector for transmission, and so maybe decreasing water birth. So I wonder if you would speak on any of these conversations that are happening nationally or globally right now.
I feel like because I'm working right now on the family practice side, so I'm more doing protecting our most vulnerable chronic care people, which are going to be the older crowd. And then this morning I was in conversation with the OB leads at our small rural hospital, who are getting, they're pulling their information in from multiple sources. And they were feeling that because the moms are generally seem to be handling when they are infected, are handling it fairly well. And whether there's vertical transmission or not, I hadn't heard of any positive babies, but that baby is likely handling that infection fairly well too, that some of the focus is shifting to the susceptibility of the care provider attending women and babies. Yeah. And whether or not they should be full PPE. But at this point, they are not. If they are not a, like, quote, person under investigation and meeting triage criteria for testing, I do not believe, at least not in our area, nobody's using PPE for that.
Really?
And in terms at this point, because they don't have the data that says that they should be doing that, and they have some reassuring data out there. So whether that changes, it seems to be the turnover of information is every 4 hours. That's
Yeah.
pretty much what we're looking at right now. So
Yeah.
I
Yeah.
can't
Yeah.
even say anything that influences anybody's practice right now because it's all super fluid, and I think that women and birth workers should definitely be protecting themselves. But there's no real clear guidance on and evidence-based guidance
Yeah.
for what to do going forward on
Yeah.
a day-to-day basis. I think you have to wash your hands and be very, very clear. And if for some reason you feel that you feel compelled, like maybe this is where we have to just get very intuitive and say,
Yeah.
hey, I feel like I need to wear a mask right now, and that needs to
Yeah.
be okay to do that.
Yeah. Well, so one of the conversations that I'm having with midwives around the U.S. is the move towards telemedicine and conducting prenatals essentially over the phone. Do you want to weigh in on this? What's your opinion here?
Yeah, I think if the primary objective is to protect both parties,
Yeah.
then I guess we'd have to use the tools that are available to us to do that. So let's say if it was Ebola, we wouldn't even be talking about this, right?
Yeah.
It would be
Yes.
telemedicine. We would not have two
Yeah.
people in the same room together.
Right.
So it's a little bit conversation, I think, when it comes to COVID-19. But telemedicine is the way, health is the way most entities are going right now, at least for this next
Yeah.
month or perhaps 2 months, to
Yeah.
protect both. And no, it doesn't allow us to, you don't get the numbers, right? You're not going to get the measurements, and then you don't have that heart-to-heart connection that you get to have with somebody when you're working in the same room with them. But maybe this will stretch us a little bit in terms of being able
Yeah.
to be able to reach through a screen and make sure that we're there
Yeah.
for each other and talk to each other
Yeah.
and be the emotional support that we are as birth workers.
Yeah.
Yeah,
Yeah,
it's
it's
tricky.
exceptional times, isn't it? It's just unprecedented, really. And the brilliant thing is that we do have the option to do exactly this kind of digital connection and telehealth and phone calls and
Exactly.
video conferencing. I mean, imagine the Spanish flu in 1918. You were just completely isolated by yourself, maybe dying by yourself. And in our current day and age,
Right.
we can reach out to each other. So yeah, it's pretty awesome, really, in some ways.
Right. It's perhaps inconvenient and maybe not ideal,
Yeah.
but I guess maybe we should just be glad that there is a way to reach out. And then
Yeah.
I think people, again, you have to find that place inside you that is creating fear-based decisions, and try to see
Yeah.
if you can just sort of wrangle that a little bit and move it to the side, and just and come from your heart center where you can intuitively move into a space that allows you, since we don't have super clear recommendations, that helps guide you into what it is
Yeah.
that you need to do. And of course, finding out what your client needs, from you,
Yeah. Yeah.
and from themselves.
Yeah. Brilliant. Brilliant. Well, Lisa, do you have
I
any
know.
tricks and tips for us? Do you have any things you want to share that's
Oh,
hands-on midwifery?
I did bring my one. Anyone who's taken my NRP class knows about this, and I'm sure, I've no doubt that you know about this, and many of the other NRP instructors know about this. But I don't really care for Dali the man, but I do like the Dali suction catheter, because we can't really get rid of this. I don't usually use bulb syringes in neonatal resuscitation. I know it's an option if you need to suction before you do next steps if you have a baby that's not doing very well. However, I'm a bit more of a proponent that if you do have to suction, that you would use a Dali catheter to do that. And one of the reasons I think that these need to be in our bags is because this one catheter actually can be repurposed times 3 besides the Dali, right? So if you were to, so everybody knows how to use a Dali probably, but if you were to sort of let the catheter part go, so here's your reservoir, and then here's the part where you're going to suction on, but that's going to be put aside. And then what you actually end up normally having is a tube that, here it is. The end of this tube fits into a Luer lock. All right, so now you've got an orogastric tube, which would be almost the same length, and it's not an orogastric tube. It's not anything that needs to be sterilized, which is really nice. So you can certainly want it clean, but you would do all your measurements, and then if you needed to decompress the stomach for some reason, you had a prolonged resuscitation, and I'll tell you that story in just a second.
Okay.
If you need to do that, you can do it with this. If you need to, you can clean it really well with povidone iodine, and if the birth and you feel compelled to decompress a bladder that is obstructing the descent of the babe, you now have a bladder catheter. If you have a baby that you are really out there and you don't have anywhere to take this baby to, this can be an umbilical vein catheter as well. You just have to know how to use it as an umbilical vein catheter. And all of that and sometimes babies, let's say there was a placental abruption or something like that, and baby lost a fair amount of blood, and it can be a life-saving intervention to be able to just give 10 or 20 mLs of normal saline and get that back into the vascular space, and this baby might make the between this baby surviving or not. And then the last thing is a supplemental feeding system. So you've got your thing, and you can just put it right there, and you've got your supplemental feeding system all set to go. So this one tube can do those 4 things, which I think is totally cool. And then the one thing I do want to mention, I was in Sierra Leone, and we had solar light only usually till about 2 in the morning. The other midwife could not join me, and I was attending a woman by myself. And everything was going perfectly normal. It was a beautiful, beautiful birth, and this baby came out completely flaccid. Heart tones were fine before baby comes out, and then there were no heart tones after baby came out. Flaccid, not looking right at all. We've seen this. If you do this work long enough, you're going to see this happen. So I did the usual first step. This baby wasn't doing much of anything, and so I started to use the bag mask. And I could get the baby's heart rate up to over 100 just by using the bag mask. So I'm in the dark. I have a flashlight. I have this mom who's going to have her birth her placenta. I've got, every time I move the bag away, the baby's heart rate would just tank. There's nowhere to go. We're just there. So we just got into this rhythm, and I would just sort of murmur sweet nothings towards mom, maintain contact with her. I was doing bedside resuscitation, and I was, we'll just keep doing this as long as it works. And then sure enough, it took roughly about 20 minutes, and I'm bagging, putting in those nice insufflation breaths, and it's getting tighter and tighter and tighter and tighter. And I knew that I was blowing up baby's stomach. And so I did not have a delete catheter. I didn't have anything. This particular room had it just didn't have much. We had scissors to cut the cord. So, and I thought to myself, well, okay, now I can't, be providing oxygenation and ventilation to this baby. This baby's stomach is clearly enlarged, and all I thought was, what needs to happen next? And you can ask this in so many different circumstances. When you find yourself up against the wall and you're not sure, because we're so used to our equipment, like this, my equipment is supposed to do this one job. So you have to get back into your head and say, what needs to happen next? And what needed to happen next is the stomach needed to be decompressed. And so I just took, this is another reason I have this, my service baby with me. I just took this little baby, and I went gently underneath the baby's rib cage, and I just pressed down and in, oh so gently, and the baby went, and I went, and then I did it again, oh so gently, down, in, up, under the rib cage, and then I started the bag again, the bag mask, no problem, no resistance. 2 hours, 20 minutes, decompress, go back to it. And then the baby started to squeak a little and grunt a little, and then was finally breathing on her own. Nursing 9 hours later, baby was nursing, not the best suck, but nursing. And then the family left. I didn't get to see them. Usually people come back, but they had gone back down to a different hospital for some reason, and I was in the market, you know, the kind of market you know about, those kind of markets, you know, just food everywhere and baskets, and this wonderful woman comes up with this beautiful baby, probably the sassiest, fattest, beautiful looking baby I'd ever seen in Kabbalah. And she said, "Do you recognize her?" And I said, "No, I don't recognize her. I don't." And then I recognized Mom. And here was this beautiful, robust baby. And I mean, certainly that was wonderful, because I didn't know what happened next. And I know sometimes those babies don't do well frequently. But that baby did do well. And I learned something so very important. I learned to trust myself a little more. I learned to think through a little more, do that critical thinking that says, what needs to happen next to get that job done so that baby can have its life too. And so that's what I teach. And I remind people that everything we learn is obviously not in a book, because there's no book that has that in it.
But it should be. So, Lisa, you ready to start writing books?
Someday. We'll see what's going to happen with that.
I feel the same way.
I know you have. You could like write for the next 20 years and not be done. All right, I wrote something here I do want to read. Is it okay? I wrote this.
Okay, please.
I said, remember, the birther's wisdom, your wisdom, the babe's wisdom are powerful allies, and when combined with the physical, emotional, spiritual health and guidance, and just a few choice tools needed to help this dyad navigate the shift in the relationship, how can we call that birth a low resource setting birth? So
beautiful.
I celebrate
I feel like
all of you and our wisdom.
Awesome. I feel like if you have a midwife with you, that's the actual definition of being high resource. Right? Right? So the low resource, the low resource births are the ones where people can't actually reach a care provider, you know. So well, thank you so much for your generous time and your deep wisdom and your clarity. I hope we have more ways to connect in the future. I'm so grateful for you.
I'm so grateful too. Thank you for asking me on, and hello to everybody. I think I saw a few little people there that I might know, which was so sweet.
It's fun, isn't it?
And thank you.
Fun.
I just knew I was a friend.
Yeah. Well,
all right.
Thank you, my friend. Take good care of yourself and do more of these. The world needs your wisdom.
Oh, thank you, Augustine. You're awesome. All right, everybody. Okay. Be well, stay well, be healthy, take care of yourselves.